Good evening, everybody. It's my proud privilege to introduce our moderators for the day. We all know that the topic today is on opioids, their pharmacology, current role, and future trends. We've heard about opioids since ages memorial, and we've been using it. The first time when the student comes to the anesthesia department and he starts looking at the drugs, opioid is a very important component. And so we thought that this is a very important PG webinar for the postgraduates. And of course, it'll be a review for all of us. For this, we have three eminent moderators. Dr. Kirti Saxena. She is currently the Director, Professor, and Head of the Department of Anesthesiology and Intensive Care at the Maulana Azad Medical College. Madam is a very important and vital member for the Indian College of Anesthesiologists. She is the editor-in-chief of the Journal of Indian College of Anesthesiologists. And we are very proud and we are really honored to have ma'am here because we have been able to start the journal. She's on the editorial board of 5 journals and she has authored more than 100 papers and several book chapters. Indeed an honor. Welcome, Dr. Kirti. The second moderator is Dr. Krishna. He is, of course, an alumni of Maulana Azad. And he's now the professor and head of the Kasturba Medical College, Manipal. He has several areas of interest: pediatric anesthesia, obstetric, and simulation anesthesia. Good evening, and thank you, Dr. Krishna. Our third moderator is Dr. Linette Morris. She is currently the professor and head of anesthesiology at the Government Medical College, Trivandrum. She has also got a keen interest in obstetric and pediatric anesthesia. While I'm introducing the moderators, I would also like to welcome the students who are going to be talking to all of us and really enlightening us, Doctors Aditi, Siva, and Yadav. So, Dr. Sanish, could we please start and welcome you all, and we're really looking forward for this webinar.
Thank you very much, ma'am. Today, I think we are having our second seminar version of our PG assembly. Before that, we were doing pro-con sessions. Okay, opioids, current and evolving concepts. We have postgraduates from Maulana Azad Medical College, New Delhi, Kasturba Medical College, Manipal, and Government Medical College, Thiruvananthapuram. Just name the most commonly used opioid in your anesthesia practice. If you still use one of them, you can write again. We'll see which one is more popular. Okay, let me go to the next question. You can still enter your remarks. We'll show it towards the end. List the side effects of opioids. You can text using your smartphone. Okay, the word cloud is building. So you're worried about respiratory depression, nausea, vomiting, pruritus, addiction, bradycardia. You can keep entering, keep your smartphone on, because this page is going to be on throughout the session. You can enter. Okay, now let me proceed to the first lecture of the PG assembly. I would like to invite Dr. Kirti to introduce the first speaker and the topic. Over to you, ma'am. Yes.
Dr. Aditi Yadav is third year PG at Maulana Azad Medical College, and she'll be giving an introduction to opioids and talking about the pharmacokinetics and pharmacodynamics of opioids, different opioids. Over to you, Aditi.
Thank you, ma'am. Good evening, respected panelists, moderators, sir, and my dear colleagues. I'm going to talk about the review of pharmacology of the opioids today. So let's begin with a look at the history of the opioids. Opioids refer to all compounds related to opium, which is nothing but the juice of the poppy plant, Papaver somniferum, and its reference dates back to 3rd century BC. In the 19th century, early 19th century, morphine was isolated from opium, which was followed by the discovery of heroin in late 19th century. And then in the 1960s, synthetic opioids were manufactured by the Janssen Pharmaceuticals. Opioids can be classified in two ways. Firstly, into naturally occurring, semi-synthetic and synthetic. And secondly, by their action on the opioid receptors into agonists, antagonists, and antagonists. Coming to the mechanism of action of opioids, opioids function by binding to G protein coupled receptors of the GIO subtype, that is of the inhibitory subtype, and are broadly of three types: mu, kappa, and delta. In the spinal cord, the receptors are principally located in the substantia gelatinosa of the dorsal horn. At the supraspinal level, they are located in locus ceruleus, periaqueductal gray, and rostral ventral medulla. The opioid binds to the opioid receptor, and the G protein coupled receptor gets stimulated. The alpha subunit gets dissociated from the beta gamma subunit, and this leads to inhibition of the adenylate cyclase enzyme, leading to a decrease in intracellular concentration of cyclic AMP. This is also followed by stimulation of the potassium channel and an outward translocation of potassium ion, and an inhibition of the voltage-dependent calcium channel, which leads to inhibition of migration of calcium ion inside the cell. This leads to hyperpolarization of the cell membrane, and thus inhibition of neuronal transmission and neurotransmitter release occurs. Hence, impulse conduction is stopped. Analgesia produced by the opioids is the property for which it is most commonly used, and it is mediated both at the spinal and the supraspinal levels. At the spinal cord level, the neurons having opioid receptors abolish the neurons having opioid receptors synapse on the afferent pain carrying neurons and inhibit them. And at the supraspinal levels, descending pain modulation is carried out by neurons in the periaqueductal gray that synapse with the interneurons in the dorsal horn and inhibit pain conduction. Now let's discuss the pharmacodynamic effects of opioids in a system-wise manner. First are the neurophysiological effects. Opioids are an excellent analgesic for nociceptive pain. The relief of pain caused by opioids is relatively selective in that other sensory modalities are not affected. Patients frequently report that the pain is still present, but they feel more comfortable. Thus, they cause analgesia without loss of consciousness. However, neuropathic pain, that is pain due to the severed nerves, is poorly responsive to opioids. At higher doses, opioids also cause unconsciousness, but opioid-based anesthesia is unpredictable and inconsistent. Therefore, they are not used as sole anesthetics. However, they are frequently combined with inhalational agents and hypnotics during general anesthesia. With inhaled anesthetics, opioids cause a dose-dependent reduction in MAC, so much so that the anesthetic potential of opioids is regularly tested by measurement of MAC. Opioids are well known to synergize with hypnotics to produce sedation. However, their ability to affect the BIS may vary depending on the context of opioid administration. Opioids generally produce modest decrease in cerebral metabolic rate and intracranial pressure, and they have no significant effect on cerebral blood flow. Opioids also cause muscle rigidity. During the rapid IV administration of large doses of fentanyl and its derivatives, muscle rigidity can be produced. The mechanism of action of this is not clearly understood, but it is thought to be mediated by mu opioid receptors, whereas supraspinal delta and kappa receptors inhibited. It is associated with hemodynamic changes like increase in central venous pressure, increase in peripheral vascular resistance, increase in pulmonary artery pressure, and respiratory changes like decrease in FRC, decrease in ventilation, and decrease in compliance. Opioids release the effect of inhibitory neurons in the Edinger-Westphal nucleus, and result in pupillary constriction. The pupillary dilatation reflex has been successfully used to assess the analgesic component of a balanced anesthetic regimen. The pupillometer is a valuable tool to guide morphine administration in the immediate post-operative period. Opioids can also cause pruritus. Characteristic facial itching is seen with opioid use. It is mediated by mu receptors and inhibited by kappa receptors. Ondansetron and pentazocine are newer drugs which can be used for pruritus relief. Some opioids are also used for treating post-anesthesia shivering, like meperidine and tramadol. They decrease the shivering threshold and thus abolish shivering. Coming to the respiratory effects of opioids, opioids have an antitussive action and they blunt airway responsiveness to endotracheal intubation. However, fentanyl, sufentanil, and enfentanil curiously elicit a brief cough in up to 50% of patients when the drug is injected by a rapid IV bolus. But the incidence of this cough decreased significantly as the injection time was increased, or by the administration of 1.5 mg per kg lignocaine 1 minute prior to fentanyl administration. The most dreaded complication of opioid use is respiratory depression, and it is mediated by mu-opioid receptors. It leads to slow, deep breaths, signifying that opioids cause a decrease in respiratory rate, significantly more than a decrease in tidal volume. High doses of opioids usually eliminate all spontaneous respiration without necessarily producing unconsciousness. This means that patients receiving these high doses may still be responsive to verbal command and often breathe when they are directed to do so. There are factors that influence this respiratory depression, like old age, concomitant use of CNS depressants, renal insufficiency, hyperventilation, and hypocapnia. Hypocapnic hyperventilation enhances and prolongs postoperative respiratory depression, and the possible explanation for this include increased brain opioid penetration due to increased unionized opioid fraction with hypocarbia, and decreased removal of the opioid due to decreased cerebral blood flow with hypocarbia. In patients who hyperventilate because of anxiety or pain, even small doses of IV opioids can result in transient apnea because of acute shifts in apneic thresholds. Coming to the cardiovascular effects, opioids cause bradycardia due to central vagal nucleus stimulation, but overall they are usually very cardiostable and are used as induction agents during cardiac surgeries. Opioids also mimic ischemic preconditioning, and morphine is used in the treatment of acute myocardial infarction. Gastrointestinal effects of opioids are as follows. They decrease GI motility via supraspinal, spinal, and peripheral mechanisms, increase biliary duct pressure and sphincter of Oddi tone, and it stimulates chemoreceptor trigger zone, causing nausea and vomiting. They also lead to constipation due to inhibition of small and large bowel propulsion movements. Now let's have a look at the individual drugs. Coming to morphine. Morphine has an onset of action of 15 to 30 minutes with a peak effect at 45 to 90 minutes and a duration of action of 4 hours. It is hydrophilic in nature and thus takes time to reach effect site, causing a delayed onset of action. Looking at the pharmacokinetics of morphine, it undergoes both hepatic as well as extrahepatic metabolism by conjugation with glucuronic acid. Two metabolites are formed, M3G, which is the major metabolite, or we call it morphine 3-glucuronide, and morphine 6-glucuronide, which is a minor metabolite. M6G is the active metabolite, which means that it can cause analgesia as well as respiratory depression. It is responsible for the prolonged action of morphine. Morphine shows increased duration of action in cases of renal failure due to the accumulation of this active metabolite, that is M6G. However, its pharmacokinetics is relatively unaltered in cases of hepatic dysfunction due to high hepatic extraction ratio as well as extrahepatic metabolism. Morphine has a pKa of 23%, pKa of 8, and at physiological pH, it is 23% unionized. and is 20 to 40% protein bound. It is associated with histamine release and causes urinary retention. The pharmacodynamic effects have already been discussed. Coming to fentanyl, fentanyl is a phenylpiperidine derivative which is 75 to 125 times more potent than morphine. It is lipophilic in nature, thus has a faster onset and greater potency than morphine. Being lipophilic, it undergoes redistribution and therefore has a short duration of action. It undergoes first pass uptake in lungs. It is metabolized by N-demethylation to form norfentanyl, which is an inactive metabolite and is excreted by the kidneys. Fentanyl is a substrate for hepatic P450 enzymes, CYP3A, and is susceptible to drug interaction. It has a pK of 8.4 with less than 10% unionized fraction at physiological pH, and it is a highly protein-bound drug. The context sensitivity half-life of fentanyl increases with longer infusions due to sequestration of fentanyl at inactive peripheral sites. This means that at the end of infusion, there is return of fentanyl from peripheral compartments to the plasma, thus increasing its context sensitivity half-life. The pharmacokinetics of fentanyl is unaltered in renal or hepatic failure. Morphine and fentanyl are two of the most commonly used opioids in the perioperative setting. So let's have a look at their contrasting features. Morphine is a hydrophilic drug, whereas fentanyl is a lipophilic drug. Morphine has a slower onset of action and a longer duration of action, whereas fentanyl has a faster onset and a shorter duration of action. Morphine is less protein bound, whereas fentanyl is highly protein bound. Morphine has active metabolites, whereas fentanyl has inactive metabolites. Morphine is associated with histamine release, whereas fentanyl is not. The pharmacokinetics of morphine is altered in renal failure, whereas that of fentanyl is not. Now let's have a look at L-fentanyl. L-fentanyl has a very low pK of 6.5, with 90% of L-fentanyl being unionized at physiological pH. Thus, it has a very fast onset of action despite being highly protein bound. It is hepatically metabolized to inactive metabolites by N-dealkylation. It has a wide inter-individual variation in its pharmacokinetic. Thus, reliable infusion regimens for TIVA are difficult to develop. Coming to sufentanil, it has an analgesic potency which is 5 to 10 times more than fentanyl. It undergoes pulmonary first pass uptake just like fentanyl. It is also highly protein bound. The context sensitivity half-life of sufentanil is less than L-fentanyl due to its high volume of distribution. This means that after termination of a sufentanil infusion, the decrease in the plasma drug concentration is accelerated not only by metabolism, but also by continued redistribution of sufentanil into peripheral tissue compartments. Coming to remifentanil, remifentanil has a fast onset and a fast offset. It undergoes metabolism by ester hydrolysis, leading to short duration of action. Its pharmacokinetics is not altered by renal or hepatic failure. It is not a substrate for pseudocholinesterase, and its context sensitivity half-life is independent of duration of infusion. Talking about opioid antagonists, Naltrexone is first. Naltrexone is a non-selective antagonist at all three opioid receptors. Its pharmacokinetics is as follows. It has a rapid onset of action and a short duration of action. Due to its short duration of action, it shows a mechanism called re-narcotization with long-acting opioids. It is metabolized to naloxone 3-glucuronide and is used in a dose of 1 to 4 microgram per kg per IV. The uses of naloxone are, it is used for the treatment of opioid-induced ventilatory depression. In low doses, it is used to block development of acute opioid tolerance. Newer uses of naloxone are, it is being used to treat shock and for cholestasis-induced pruritus. Its side effects are nausea and vomiting, and due to severe stimulation because of increased sympathetic nervous system activity, it leads to tachycardia, hypertension, and cardiac arrhythmias. Coming to naltrexone, Naltrexone is very similar to naloxone, but with a longer duration of action, and it is active when taken orally. Next is nalmefene. Nalmefene has a greater preference for mu receptors and is equipotent to naloxone. It is longer acting and has a higher bioavailability. Next is methyl naltrexone. It is a quaternary ammonium compound which does not cross the blood-brain barrier. This means that it reverses opioid effects mediated by peripheral receptors like constipation without affecting its central effects like analgesia. Thus, it is used for the treatment of opioid-induced constipation. It is also used for the treatment of opioid-induced nausea and vomiting, as the chemoreceptor trigger zone lies outside the blood-brain barrier. And it is also used for the treatment of post-operative IVs. Now let's have a discussion on neuraxial opioids. Neuraxial opioids is the placement of opioids in the epidural or the subarachnoid space for pain management. It is not associated with sympathectomy, sensory or motor blockade like local anesthetics. They produce dose-dependent analgesia by three mechanisms. First, by binding to mu-opioid receptors in the spinal cord. Secondly, by systemic absorption. And thirdly, by cephalid migration of the opioids. The pharmacokinetics of epidural opioids is dependent on their lipid solubility. And lipophilic and hydrophilic opioids behave very differently. Opioids placed in the epidural space may undergo uptake into epidural fat, or they can undergo systemic absorption, or they can diffuse across the dura mater into the CSF. The diffusion across the dura depends on lipid solubility, and hence the CSF concentration of lipophilic opioids peaks within minutes, whereas that of hydrophilic opioids peaks in hours. Lipophilic opioids show faster systemic absorption, whereas hydrophilic show slower systemic absorption. Lipophilic opioids are associated with early depression of ventilation, whereas hydrophilic opioids are associated with delayed depression of ventilation. Lipid-soluble opioids are limited in their cephalid migration by uptake into the spinal cord, whereas less lipid-soluble opioids remain in the CSF or transfer to more cephalid location. The side effects of the neuraxial opioids are as follows. Most common side effects of neuraxial opioids is pruritus, which is localized to face, neck, and upper thorax. It is likely mediated by interaction with the mu-opioid receptors in the trigeminal nucleus. They also cause urinary retention in non-dose dependent manner due to stimulation of mu receptors in sacral spinal cord, which leads to inhibition of the parasympathetic outflow and thus detrusor muscle relaxation. This urinary retention can last for up to 16 hours after epidural injection. The most dreaded complication of neuraxially administered opioids is depression of ventilation. It can be early or delayed. The early depression of ventilation commonly manifests within 2 hours of epidural injection and is thought to be due to the systemic absorption of the opioid, whereas the delayed depression of ventilation occurs after 6 to 12 hours of epidural injection and is due to the cephalid migration of the opioids. The other side effects are nausea and vomiting and sedation. Lastly, let's look at this the opioid sparing analgesia. Due to there are growing concerns regarding liberal opioid use for acute and chronic pain management, and opioids have high abuse potential and cause opioid dependence. There are concerns regarding opioid-induced hyperalgesia and cancer recurrence. So there is a shift to non-opioid medications for pain relief like ketamine infusion, lignocaine infusion, dexmedetomidine, magnesium sulfate, and beta blockers. Having said that, opioid-free and opioid-sparing analgesia both present with their own challenges. These are the references that I cited. Thank you very much.
Thank you, Dr. Aditi. So that was quite a detailed presentation on the pharmacokinetics and pharmacodynamics of and side effects of opioids. And even though she talked about opioid free and all that, but opioids still remain the mainstay of anesthesia, general anesthesia as well as sedation.
And shall we move to the next topic?
Yes, yes, of course.
Okay. So while moving on, we still have audience interaction voting panel open. So we would like to know from your practice, can you grade the impact of opioid side effects in your practice? Because Dr. Aditi has mentioned or enumerated the complications. So we have listed a few of them. So once you log into www.menti.com and log in using the code 69579556, you can use your smartphone to post your vote. Okay. Would like to hear from you because subsequent sessions, actually, we are discussing into how we make use of opioids in our anesthesia practice. Okay, we'll go to one more question. What is your choice of opioid as adjuvant in epidural analgesia? So whatever you are using, you can post it, just text it, your choice, maybe one choice. Okay, fentanyl has come, morphine has come. Yes, again, fentanyl. Yes, morphine again. Okay, the voting pad will be still open. You can still vote. I think it's time to move on to the next lecture. We have from Kasturba Medical College, Manipal, Dr. Krishna and his postgraduate. I welcome Dr. Krishna to introduce the postgraduate and introduce the second topic.
Thank you, Dr. Sanish. Good evening, everybody. It's indeed a proud moment for me to share this platform with both my teacher here, Dr. Kirti Saxena, and my student as well, Dr. Siva. Dr. Siva is pursuing his final year MD Anesthesiology at Kasturba Medical College, Manipal. He's a very enterprising and enthusiastic postgraduate and was very keen to participate in this because this would give him a platform to develop into a teacher probably in the future. He has several areas of specific subspecialty interests like intensive and critical care, pediatric anesthesia, difficult airway. And he has also participated in several of the conferences where he has presented the papers and posters. He will now take us through the current clinical use of the opioids in our anesthetic practice. Over to you, Dr. Siva.
Good evening, everyone. Thank you, sir. Good evening, everyone. The topic is opioid use in current practice. We'll go through the objectives of the lecture. Planning to go ahead with opioids and balanced anesthesia, opioid analgesia, opioid use in post-anesthesia care unit, high-dose opioid induction technique, and opioids in palliative medicine, and a special note on Remy fentanyl. Balanced anesthesia. For balanced anesthesia, for this, we need amnesia, analgesia, muscle relaxation, and abolition of autonomic reflexes. For this, an anesthesia with a single agent can often require a huge doses. It can produce excessive hemodynamic instability. So still opioid remains as an indispensable agent for general anesthesia. So the inclusion of an opioid as a component of general anesthesia can reduce the preoperative pain and anxiety. It decreases the response to the airway manipulation, and it can improve the hemodynamic stability and the lower requirements of inhalation agents. Opioid analgesia, again used to relieve pain during general, monitored anesthesia care and regional anesthesia. A single bolus administration of an opioid can provide significant pain relief. And this opioid can be used as many ways, like infusion, as an additive to regional anesthesia, and through patient-controlled analgesia. As already pharmacology is dealt, an IV boluses of fentanyl at a dose of 1 to 3 microgram per kg, alfentanil or sulfentanil, can give potent and short-lasting analgesia, whereas morphine takes time to act, but can provide a longer-lasting analgesia. Patient-controlled analgesia with opioids is widely acceptable for post-operative analgesia, but the effect side the drug concentration should be calculated prior administration. Coming on to specific analgesics which are commonly used, morphine, intravenous route at a dose of 0.05 to 0.1 milligram per kg can produce a duration of action of 2 to 7 hours. An intramuscular route can produce a duration of action of 2 to 7 hours. An epidural or a spinal dose of 30 to 50 microgram can produce a duration of action of 12 to 24 hours. A strong analgesic can be used during intraoperative and postoperative, depending on the duration of the needed. Depending on the duration of the procedure, the analgesia can be selected. Fentanyl, intravenous dose of route of 1 to 2 microgram per kg gives a duration of action of 30 to 60 minutes, whereas epidural or spinal at a dose of 5 to 25 microgram can produce a duration of action of 4 to 8 hours. The rapid onset and the short duration of action of fentanyl makes it ideal for both intraoperative and postoperative analgesia. Coming on to less commonly used like sulfentanil, which is 12 times more potent than fentanyl. The route of intravenous route of 0.1 to 0.4 microgram per kg is used, whereas in sulfentanil induced skeletal muscle rigidity can reflect the obstruction at the level of the glottis or the above, can overcome, which overcome by tracheal obstruction, tracheal intubation. Whereas alfentanil, which is less potent than fentanyl, and a dose is used of 10 to 20 microgram per kg. Codeine, though most commonly not used in a route of oral or intramuscular, still used in some antidepressives. 60 milligram of codeine can provide an equivalent of 650 milligram of aspirin analgesia. Whereas methadone at a route of oral or intravenous, 20 milligram can provide a postoperative analgesia lasting more than 24 hours due to prolonged elimination of time. Tramadol is used in a route of oral, intramuscular, or intravenous. In a dose of 3 milligram per kg is effective for the treatment of moderate to severe pain. Whereas buprenorphine is an agonist-antagonist opioid, which is available in a route of intramuscular, epidural, or intrathecal. And a dose of 0.3 milligram intramuscular is equivalent to 10 milligram of morphine, 3 milligram per kg. It can also be given IV, onset of 30 minutes, and the duration of action is at least 8 hours, which is effective in moderate to severe pain. Pentazocine is available in a route of oral, intravenous, or epidural, can be given. 10 to 30 milligram intravenous or 50 milligram orally can provide a good analgesia for moderate pain. Whereas butorphanol in a route of intramuscular or intranasal can be given. In a dose of 2 to 3 milligram intramuscular provides an analgesia similar to 10 milligram of morphine. Nalbuphine, one of the most commonly used in postoperative analgesia, route is intravenous or intramuscular, whereas 10 milligram of IM provides us analgesia similar to morphine, and a dose of 10 to 20 milligram of IV nalbuphine can reverses the postoperative depression of ventilation caused by fentanyl. Whereas nalorphine is equally potent with morphine as an analgesic, but is not clinically used because of the high incidence of dysphoria. These are the opioid agonist antagonist available in India. And coming on to agonists, morphine, fentanyl, tramadol, methadone, codeine, and oxycodone are available in India, whereas agonist antagonists, pentazocine, nalbuphine, buprenorphine, and butorphanol is available. Opioid role as an adjuvant, it prolongs the duration of blockade, it decreases the total volume of the local anesthetic needed, and by the above point, it decreases the complications associated with local anesthesia, and it also potentiates the analgesic effect of local anesthetics. It potentiates the local anesthesia by G-protein coupled receptor mechanism, causing hyperpolarization of the afferent sensory neurons. Morphine is one of the most commonly used. In intrathecal morphine in a dose of 100 to 200 microgram has good analgesic efficacy. And use of morphine in peripheral nerve blockade failed to show any advantage over the other routes. Intrathecal fentanyl at a dose of 10 to 25 microgram, it prolongs the duration and the extent of the sensory blockade. And sufentanil intrathecally at a dose of 5 milligram prolongs the blockade. Intrathecal buprenorphine at a dose of 75 to 150 microgram has good efficacy and in a dose of 0.3 milligram as an adjuvant to peripheral nerve blockade provides a good analgesia. Intrathecal tramadol can also be used as an adjuvant and many trials are going, but incidence of nausea and vomiting still remains a concern. Moving on to opioid use in post-anesthesia care unit. WHO recommends a multimodal approach to pain management, especially in the post-anesthesia care unit. The principle involved in post-anesthesia pain management should include an early mobilization, early enteral nutrition, and attenuation of post-operative stress response. The cornerstone of the post-operative pain management with the advantage of no analgesic ceiling effects is seen in opioid, which means there's no need to change an opioid. And if opioid is early introduced in post-anesthesia pain management, it reduces the use of other agents which is needed for the pain control. And the efficacy is limited by the development of tolerance or the opioid-related side effects. Various routes and methods of opioids can be used in post-anesthesia care unit. Intravenous or intramuscular administration can be used for moderate to severe pain. The perineural fentanyl, which is used as an additive local anesthesia, reduces the pain scores in post-anesthesia care unit. And patient control analgesia with fentanyl reduces the pain and the post-operative stay in the post-anesthesia care unit. The picture showing the patient using the patient control analgesia, one of the most commonly used, and for a background infusion along with this, the patient control analgesia is used, reduces the stay and decreases the respiratory complications. The disadvantage that can go in the patient control analgesia is the equipment failure and the patient doesn't know how to use this pump can be the most commonly seen while using patient control analgesia. Extended release epidural morphine, where a single dose extended release epidural morphine injection provides a good analgesia for 48 hours without any need of epidural catheter. An ionophoric transdermal system allows the patient to self-administer the pre-programmed doses, which are without invasive, in a non-invasive way, and can provide equal analgesia compared with morphine patient control analgesia. A word on high-dose opioid induction technique. It is mostly used in bypass procedures, which causes significant alterations in the pharmacokinetics of most opioids. It is due to the distribution volumes or the changes in the acid-base balance, the organ blood flow, plasma protein concentration, and the body temperature. And the binding of the opioid to the components of the bypass circuit can also alter the opioid pharmacokinetics. In these cases, where the total fentanyl concentration when it is used initially for the induction can remain relatively stable during the bypass and until the near end, which makes the patient more comfortable. In patients with poor myocardial function where controlled ventilation for several hours is expected, an high-dose opioid induction technique is used. This large dose opioids using has two disadvantages. One is it delays the time of extubation, and it also can cause bradycardia and chest wall rigidity. Typically, a dose of fentanyl of 10 to 25 microgram per kg or sufentanil 1 to 3 microgram per kg is used for this technique. But the use of high-dose opioid induction is coming down because of the use of etomidate and other analgesia. One more word on opioid use in palliative medicine, where current concerns specific to opioid treatment in palliative are mainly addiction, tolerance, and side effects, because a long stay of opioid use is needed in palliative patients. And mostly morphine is used due to low cost and availability, where initially a oral morphine sustained release or immediate release, example 10 to 15 milligram 12 hourly or a total of 20 to 30 milligram per day is used. If at all hepatic or renal comorbidities is present in palliative medicine patients, European Anesthesia Association for Palliative Care recommends 1/6 of the total 24 hours dose. The table showing the transdermal patch of fentanyl in a dose of 12 microgram is equivalent to oral morphine of 45 milligrams per day analgesia, and buprenorphine used in a transdermal patch is equivalent to 30 milligrams per day of morphine. The other routes used in palliative medicine are intravenous and subcutaneous. Intravenous provides a good pain relief and early pain relief, more quicker than the subcutaneous, but you need monitoring and use for severe or unrelieved pain, whereas subcutaneous injections are the first line for patients unable to swallow or use a transdermal patch. Other routes of opioids are also used in palliative. One is rectal morphine, which provides a good pain relief and with a faster onset, but the route is unacceptable to some patients, especially in lower GI involvement. An epidural is equally efficacious, but complications such as CSF leak and hypotension occur, and constant monitoring is needed whenever opioid used in epidural route in palliative medicine. Saying all this, in search of an ideal opioid should permit rapid titration, should permit unwanted response to stimuli, should not depress the cardiovascular function, and should permit the return of spontaneous ventilation in a timely manner. Of all this, we have come close to this. In search of an ideal opioid, we have got remifentanil, though not available in Indian market. It's a pure mu opioid receptor agonist, suitable for general anesthesia and conscious sedation because of its rapid onset and offset coupled with the synergistic effects. It is rapidly metabolized by non-specific plasma and tissue esterase, and the metabolite, which is remifentanil acid, which undergoes renal excretion and minimally accumulates in patients with reduced renal function. Coming on to side effect profile in remifentanil, cardiovascular effects include hypotension, bradycardia, and rarely asystole. Respiratory effects include respiratory depression and apnea, and gastrointestinal, nausea, vomiting, and constipation are seen. Neurological patients are associated with delirium and skin pruritus, and musculoskeletal, postoperative shivering and muscle rigidity is seen, and withdrawal hyperalgesia, even after short infusion, is seen higher with remifentanil. This is the graph showing the context-sensitive graph of remifentanil. In this, the x-axis has the duration of infusion in minutes, and the y-axis, the time at which 50% drop in concentration at the effect site is seen. Remifentanil almost has a linear curve, showing that even after remifentanil is stopped just before the end of the surgery, it doesn't show much of accumulation at the tissue, and the effect site concentration comes down rapidly, and so that it can be used in a longer time procedures. And this also poses a disadvantage of need of a rescue analgesia. A high intraoperative dose of remifentanil has always been associated with postoperative hyperalgesia. And because of this, morphine context sensitive half-life is small, morphine is needed, or an alternative should be at least half an hour given prior before stopping the infusion to allow it to reach peak effect so that the patient doesn't complain of pain during the postoperative period. TCI pumps are used in which adjust the rate of infusion and achieve steady state effect site concentration based on two things. One is the pharmacokinetics of the drug and physical characteristics of the patient. Whenever remifentanil is used, the pharmacokinetics of the remifentanil should be kept in mind for the procedure. Clinical application of remifentanil, it varies in the other compared to the other agents. In case of during GA, it requires the effect site concentration of 3 to 10 nanogram per ml or about 0.1 to 0.3 microgram per kg per minute. And it has a potent respiratory depressant effect, and spontaneous can be challenging with high rates of infusion. The advantages include it is safe in malignant hyperthermia as it reduces the need for the higher doses of propofol due to the synergistic action. And it has a relatively short context-sensitive half-life of only 3 to 4 minutes, and it takes only 6 to 12 minutes for a patient to resume spontaneous ventilation after the infusion is stopped. And this makes the remifentanil useful for a longer operations and where the rapid wake-up is desirable. It also allows intubation without muscle relaxant, since it obstructs the airway reflexes and allows intubation without muscle relaxant in adults and children. And the advantages includes in population with abnormal sensitivity to muscle relaxant, example allergy or myasthenia gravis, there it can be used. And it also can be used in assistance of nerve stimulators, example for monitoring facial nerve function during mastoid or parotid surgery, and where avoidance of incomplete reversal or recurrization is desirable, and in patients where less risk of awareness is expected. Can also be used in intensive care medicine, where maximum benefit over other short-acting opioids in terms of short context half-life and minimal accumulation, which makes it ideal for spontaneous breathing, and a rapid offset for early neurological assessment during sedation holds, and no dose adjustment is needed in chronic or acute kidney injury, though the accumulation rate is very, very less. and profound respiratory depression, which helping to avoid patient ventilator dysynchrony. This is mostly not seen in modern ventilator, which is used in intensive care unit. Coming on to the Remy-Fentanyl extubation technique, in cases where a smooth extubation is needed and where there is need to avoid rise in intracranial pressure or the intraocular pressure, Remy-Fentanyl extubation technique can be used. In this, an infusion rate of less than 0.1 microgram per minute is allowed to run in a background of Remy-Fentanyl infusion. And extubation is performed just after the patient has started to follow oral commands. This occurs typically before spontaneous efforts or the return of airway reflexes, and thereby the intracranial pressure or the intraocular pressure can be avoided in the procedures where it is needed. These are my references. Thank you.
Thank you, Dr. Siva. I think at the end of your talk, we are convinced that the use of opioid is not just juggling with the numbers or the route of administration. It's just like any other aspect of anesthesia. It's an art which we can get better every day by closely watching our patients. And you have primed us and prepared us to accept Remy-Fentanyl any moment it becomes available in Indian market. Thank you. Over to Dr. Sanish.
Thank you very much, sir. That was a nice.
Thank you, sir.
Okay, we'll move ahead. Before that, I would still request the audience to join with your opinion. Remember, those who are watching this in YouTube later may not be able to join the survey. So those who have joined live, please enter the code and join us, give your remark. So the audience question number 5 is factors increasing the magnitude and or duration of opioid-induced respiratory depression are all except high dose, old age, inhaled anesthetics, benzodiazepines, and increased clearance. You can look at your smartphone. The options will be on the screen. Increased clearance is one response we have obtained. We'll wait for a few more seconds. Yes, next person also voted for increased clearance. So next, we would like to listen to you. Do you have opioid antagonist Naloxone, as mentioned by Dr. Aditi in the first lecture, in your operating room? Do you keep the antagonist while using the agonist? Yes, so far the 100% response is yes. I think Dr. Aditi mentioned about some more antagonists. So we'll confine our discussion to Naloxone. So after the third lecture, during the panel discussion, we'll bring all these issues back into the discussion part. So now we will move on to lecture number 3 from Government Medical College, Trivandrum. And now it's over to Dr. Linette Morris to introduce the third speaker and the topic. Over to you, ma'am.
Good evening, everybody. Am I audible?
Yes, yes, ma'am. Please go ahead.
So after having heard 2 lectures on morphine, now we move on to a relatively new topic and on opioid-sparing anesthesia, which will be spoken for the next couple of minutes by Dr. Ansha, who is a third-year resident at Government Medical College, Trivandrum. Now, what are the concerns? Why this topic has come up is because the use of opioids in surgical patients has been contributing to certain important factors, especially the enhanced recovery program, which advocates opioid-sparing techniques so as to reduce the incidence of post-operative side effects and also to improve functional recovery. There are also certain concerns regarding the use of opioid and the recurrence of cancer because of the effect of opioids on immune modulation. So with these concerns, now we move on to the next topic of opioid-sparing anesthesia in surgical patients. Over to you, Dr. Ansha.
Good evening, everyone. My topic is opioid-sparing anesthesia, a different regard to anesthesia practice. So, a brief introduction. So, opioids remain the mainstay of modern perioperative care and pain management, and providing analgesia, they provide the advantage of providing analgesia without the loss of touch, proprioception, or consciousness. And opioid refers to all the drugs that have been derived from the papaver somniferum, and opioid means all the exogenous and endogenous substances that act on the different subset of opioid receptors to produce an agonistic action. We have dealt with the history of opioid use in detail. I would like to highlight only two major landmarks in the history. One was the contribution by Dr. John Lundy, an early pioneer of IV opioids. He first presented the idea of balanced anesthetic in his publication in 1926 and 1931. And by this concept, what he meant was the use of multiple drugs in small doses rather than using one or two drugs in large doses. So this use of multiple drugs in small doses could provide a combined advantage of optimal effect, and at the same time reducing the side effect. And second landmark was the discovery of fentanyl in 1960, and it was first described for use in anesthesia in 1962. The effectiveness and hemodynamic stability quickly cemented the place of opioids as a routine part of modern balanced anesthetic. So by now, now opioids have become the cornerstone of pain management, both perioperative, that is intraoperative, postoperative pain management, chronic pain conditions, cancer pain, etc. Thus, opioids have become more and more popular, and now there arrives the opioid epidemic. So, that opioid epidemic can be traced back to the late 1990s when the US State Medical Board began to loosen the restriction for the prescription of opioids. So what happened was that there was overprescription of opioids, and soon later after this, pain began to be popularized as a fifth vital sign, and there was widespread acceptance for aggressive pain management and liberalization of prescription of opioids. So there was overprescription and overuse of opioids. So from 1997 to 2007, the retail sales of opioid medication saw an overall increase by nearly 149%, which was a tremendous increase. And this was the modern opioid epidemic. And there is a myth, I'll explain that later. And this opioid epidemic led to the devastating consequence of opioid crisis, wherein there was increasing number of deaths related to prescription opioid use, that was due to overdoses, misuse of prescriptions, addictions, and there was rising number of newborns experiencing withdrawal syndrome. So this was a picture showing the opioid epidemic. So the first map shows the drug mortality in 2005. So the red color shows the drug mortality. And we can clearly see that the drug mortality has risen tremendously from 2005 to 2014. And this is another chart that shows the drug overdose deaths by individual drugs in 2016. And now we have reached a somewhat grave situation. And it's time for us to think what we can do. So, 4 questions should ideally arise in our mind in this context. So before that, I would like to tell the IASP definition of pain. That is, pain is an unpleasant sensory, IASP definition of pain. Pain is an unpleasant sensory or emotional experience due to potential or actual tissue damage. And also nociception is the neural process of sensory recording and encoding noxious stimuli. So we should think pain is a subjective phenomenon or experience with some physiological consequence. Why do we use analgesics such as opioids in an unconscious patient? So actually the term pain, which is a subjective term, should not be used in the context of a patient who is under GA, and it should be replaced by the term nociception. And why do we not avoid the use of opioids in unconscious patients and approach the physiological consequence of nociception with drugs that are specifically targeted at blunting the sympathetic system? Another question is, are opioids the best way to control pain? And the answer is actually clearly yes, though it has a large number of side effects like myocardial depression, hypotension, histamine release, respiratory depression, chest wall rigidity, that can lead to difficulty in ventilation of the patient, sedation, nausea, vomiting, placental transfer, pruritus, addiction potential, etc. Still, opioids remain the best way to control pain. And another question is, are opioids always important in control, are always effective in controlling pain? So here comes the term opioid-induced hyperalgesia. That is, when we use large dose of opioids in drop, there is chance of development of acute tolerance due to activation of pro-nociceptive process, leading to a paradoxical increase in pain sensation. And this can lead to failure of opioid in effectiveness in controlling pain. So before going to terms opioid sparing and opioid-free anesthesia, I would like to explain a term balanced multimodal analgesia, without which the two concepts will not be possible. Balanced or multimodal analgesia is the combination of drugs with different anti-nociceptive action. So opioids can be used in lower doses along with non-opioid pharmacology drugs and regional or local anesthesia. And multiple analgesics in small doses can reduce the side effects and provides optimal analgesia and helps us to achieve the combined goal of hypnosis, immobility, sympatholysis, autonomic stability, and analgesia. But we should always keep in mind the chance of unfavorable drug interactions and the chance of unfavorable side effects. And this is a definition of opioid-free anesthesia that I have got from this editorial. They define opioid-free anesthesia as a perioperative care strategy that maximizes non-opioid modalities for anesthesia and analgesia and reserves the use of opioid for severe acute pain unrelieved by other methods from admission to discharge. So actually, it is a practice. Opioid-free anesthesia is a practice that completely excludes the use of intraoperative, systemic, neuraxial, and intracavitary opioids. It is actually a multimodal analgesia technique without using opioids. And opioid-sparing anesthesia or opioid-sparing balanced anesthesia is a less restrictive form, where small doses of opioids are used. That is, it is a multimodal analgesia concept with small doses of opioid sparing. So what is the basis of this opioid-free anesthesia or opioid-sparing balanced anesthesia? So one concept that has been explained is the presence of an endogenous opioid system that is finely tuned and that can interact with other systems in our body like the immune system and the endocannabinoid system. So surgical stress can increase the endogenous beta endorphin level, and these endogenous endorphins can not only activate the opioid receptor but also activate the endosomal opioid receptor via a ligand-gating mechanism. So this creates a memory of opioid action in the cell by a sequential wave of opioid receptor and endosomal activation. And chronic use of opioids can distort this endogenous pattern. And by this opioid-free and opioid-sparing technique, we are actually harnessing this endogenous opioid system and using the benefits of activation of this endogenous opioid system. The beneficial patient group. The beneficial patient groups are patients with OSA and COPD and obese patients who have the greater chance of developing respiratory depression. Then opioid tolerant patients, that is patients who are already having chronic pain and is on treatment with opioid. So when these patients are already tolerant to opioid, they may require higher doses of opioids intraoperatively that can lead to even toxicity in these patients. And opioid addicted patients, the geriatric patients who also have chance of developing respiratory depression. Then another two things that need special mention here is oncosurgery and enhanced recovery after surgery protocols. So coming to role of opioid in cancer surgery. So I would like to deal a bit in detail about the opioid immune modulation and cancer recurrence. So opioid can alter immunity because the opioid receptors are present in immune cells like the B cells, T cells, B cells, T cells, macrophages, neuroglial cells, NK cells, etc. So they can alter immunity via either neuroendocrine effect or via direct effect on the immune system. So they can alter the development, differentiation, and function of the immune cells, particularly NK cells. And the natural killer cells are involved in apoptosis of the target cell, which are a major factor in tumor surveillance. So the opioids have, as per studies, have shown that there is chance that opioid-induced immunosuppression can result in cancer recurrence. But at the same time, from another point of view, we have to think that is uncontrolled pain and stress can result in free radical changes in the patient, and this can also cause cancer recurrence. So this field requires more studies to bring out a conclusion. Next is the enhanced recovery after surgery protocol. So this is one more thing about opioid immune modulation. It was a study conducted by Gupta et al. Showed that morphine had been associated with microvascular endothelial cell proliferation and angiogenesis, leading to tumor progression. Then next is enhanced recovery after surgery protocol. So this is actually multimodal perioperative care pathway that has been designed to achieve early recovery after surgical procedures by maintaining the preoperative organ function and reducing the profound stress response following surgery. It was actually initially tried for colorectal surgery, then it has been brought out to other surgeries like thoracic surgery, vascular surgery, and now even to radical cystectomy procedures. So the opioid sparing technique has been a major component of this ERAS protocol. And the key principles include preoperative counseling, optimization of nutrition, standardized multimodal opioid sparing analgesic and anesthetic regimen, and early mobilization. So there has been a myth related to this. That is, many thoughts are coming out that is ERAS protocol uses opioid-free regimen or advocates opioid eradication, but actually it is not so. Actually, ERAS protocol advocates opioid sparing regimen. So whenever the patient is having pain, the patient or breakthrough pain, it is often managed with small dose of opioid. And if at all the patient complains of pain at the time of discharge, patient is discharged with small doses of opioid. So it is not a technique that considers opioid eradication, but it actually involves opioid sparing techniques. Next, what are the techniques of opioid sparing? So it could be pharmacological agents and regional anesthetic techniques. Pharmacological agents include non-steroidal anti-inflammatory drugs, acetaminophen, NMDA antagonists like ketamine, magnesium, amantadine, dextromethorphan, gabapentinoids like pregabalin, gabapentin, alpha-2 agonists like dexmedetomidine, clonidine, parenteral local anesthetics like IV lignocaine, glucocorticoids like dexamethasone, antidepressant drugs like duloxetine, tricyclic antidepressants, esmolol, and caffeine. And regional anesthetic techniques can also be used for opioid sparing. So this is the chart that shows the non-opioid adjuvant. Now I would like to tell about some of the opioid-free protocols that have been tried out and their inferences. So many of the opioid-free protocols have been tried out in bariatric surgeries. One such study was conducted by Moorman and colleagues, reported an opioid-free protocol that revolves around a multimodal analgesic regimen. So they actually use ketamine, 0.25 mg per kg, magnesium, 40 mg per kg, lidocaine, 1.5 mg per kg, all these times the ideal body weight, and dexmedetomidine, 1 microgram per kg, ideal body weight, were administered as boluses at the time of induction of anesthesia, with the exception of dexmedetomidine. Dexmedetomidine was given at least 10 minutes prior to induction, and the analgesic medications were continued during the procedure as continuous IV infusion until the end of procedure, with the exception of ketamine, which was discontinued 30 minutes before the end of procedure. And intubation was achieved with propofol and procuronium and maintenance with desflurane titrated together by spectral index scale of 40 to 60, dexamethasone, droperidone, and ondansetron were administered for postoperative nausea and vomiting prophylaxis. Acetaminophen and NSAIDs were also administered at the end of procedures. And the authors of the study were able to create a reliable anesthetic with minimal or no opioids. So I would like to explain some of the drugs that has been used in this study. So all these drugs have multiple modes of anti-nociceptive action, and when brought together, they bring about excellent analgesia. So ketamine is an NMDA antagonist. So there is non-competitive antagonism of the glutamine at the NMDA receptor, resulting in NMDA antagonism. This mainly occurs in the anti-nociceptive action is mainly by the action in the secondary afferent neuron in the dorsal horn of spinal cord. And ketamine have proved to be beneficial in opioid tolerant and opioid naive patients, but we should always keep in consideration the side effects of ketamine, like the psychomimetic side effects, increased salivation, hypertension, tachycardia, neurotoxicity, etc. And another drug, which is also an NMDA antagonist, was magnesium. And magnesium is an NMDA antagonist and a calcium channel blocker, and both these together bring about anti-nociceptive action. And the magnesium, the adverse effect of magnesium is and patients should be closely monitored about the toxicity of magnesium. And magnesium can also interact with the non-depolarizing muscle relaxants to prolong their blockade. And another drug that they used with anti-nociceptive action was lignocaine. The anti-nociceptive action of lignocaine was mainly due to the blockage of mainly due to the decreased release of the inflammatory mediators like interleukin 6 and 8, and also due to NMDA antagonism. And care should be taken while we are giving to avoid local anesthetic systemic toxicity. We have to calculate the toxic dose and give accordingly. And next is dexmedetomidine. Dexmedetomidine, clonidine, and tizanidine are alpha-2 agonists that also have alpha-2 adrenergic agonists that have anti-nociceptive action. Dexmedetomidine has both peripheral and central action, and dexmedetomidine can act both in the ascending and descending pain pathways. And alpha-2 adrenergic action mainly occurs in the locus coeruleus and the substantia gelatinosa of Rolando. And the side effects that can occur are bradycardia, hypotension, initial hypertension, and prolonged sedation that can prolong the duration of recovery, and that can sometimes prolong the ICU stage also. Next drug that was used was dexamethasone. Dexamethasone is a synthetic glucocorticoid. It has anti-inflammatory and therefore analgesic action. And dexamethasone, while using dexamethasone, we should be careful about the perioperative hyperglycemia, can result in poor wound healing and increased chance of infection. And also the patient can have neuropsychiatric disturbances. Other drugs that were used in this study was acetaminophen and NSAIDs. And acetaminophen actually has causes one mechanism is through cyclooxygenase inhibition, resulting in decreased production of inflammatory mediators. And another mechanism that has been recently studied is the increased production of the increased stimulation of the vanilloid and the endocannabinoid receptors. And acetaminophen also inhibits the descending serotonergic, activates the descending serotonergic pathway. And NSAID like diclofenac and ketorolac can also be used. So their mechanism of action is they are non-specific cyclooxygenase inhibitor, but we should always be careful about the side effects like GA bleeding, platelet dysfunction, and worsening of renal function. And the dreaded side effect of diclofenac, that is IV infusion of diclofenac, can result in what is known as the Coyne syndrome, that is anaphylaxis-induced coronary vasospasm, which can result in sudden and pulseless electrical activity and asystole. Next, opioid-free protocol. This was also tried in bariatric surgery. Mueller and colleagues in a randomized controlled trial of 43 patients examined postoperative opioid consumption and quality of recovery in opioid versus opioid-free treatment arm. And patients in the opioid-free treatment arms were administered loading dose of dexmedetomidine, ketamine, and lidocaine before induction and maintained on lidocaine and dexmedetomidine infusions. And patients in the opioid treatment group were administered sufentanil before induction and maintained on sufentanil infusion. And both treatment groups were maintained intra-op with propofol, rocuronium, sevoflurane, titrated to maintain a BIS of 40 to 60. And post-operative analgesic regimens were the same in both the treatment groups and included scheduled paracetamol and a morphine patient-controlled analgesia. An inference of the study was patients in the opioid-free group were found to have a statistically significantly higher quality of recovery. The incidence of post-operative nausea and vomiting and shivering were also significantly lower in the opioid-free group, and total morphine consumption was also lower for the opioid-free group during their PACU stay. And next opioid-free protocol I would like to tell is a study that has been conducted in minimally invasive hysterectomies. So it was a study that was conducted by Blanton and colleagues who performed a systematic review investigating non-opioid pharmacologic interventions in the setting of minimally invasive hysterectomies. Post-operative analgesic consumption and post-operative pain scores were the primary outcomes that were examined in the study. Interventions include local anesthetic wound infiltration, transverse abdominal spleen block, paracervical block, gabapentinoids, IV acetaminophen, ketorolac, dexamethasone, and dexmedetomidine. So here I would like to tell about the regional anesthesia techniques that could be used as opioid sparing techniques. For upper limb surgeries, so we know that now regional anesthesia techniques are becoming more and more popular, and with the advent of ultrasound guided blocks, we are able to provide more effective blocks with lesser number of complications. So for upper limb surgeries, we can go for blocks like the brachial plexus block, that may be axillary block, interscalene block, supraclavicular block, intraclavicular block. Lower limb surgeries, the femoral block, fascia iliaca block, obturator nerve block, sciatic nerve block, and truncal block. For example, the transverse abdominal spleen block and the quadratus lumbarum block for abdominal surgery, and for abdominal and gynecological surgery. Then PEG block, PEG 1 and PEG 2 block, and serratus anterior block for mastectomy and wrist fractures, erectus spinae block for thoracotomy. So these are the blocks that could also be involved. And neuraxial techniques like spinal epidural techniques can also provide useful in treating intra and postoperative pain and decrease the opioid requirement post-op. Then another drug that I would like to mention here is the gabapentinoids. Gabapentinoids include pregabalin and gabapentin. So these act via the bind to the alpha-2 delta subunit of the calcium channel, thereby preventing the entry of calcium in the cell and decreasing the release of substance P, calcitonin-related protein, and many neurotransmitters, thereby blocking pain transmission. And gabapentinoids could have the side effect of blurred vision, sedation, etc. So other drugs that were studied include the antidepressants like duloxetine tricyclic antidepressants, esmolol, caffeine. So esmolol had blockade of the excitatory effect of the pain signaling in the central and peripheral nervous system and modulation of central antinociceptive activity. And caffeine provided improved analgesic drug absorption due to increased gastric blood flow, and it also caused a decreased hepatic blood flow. As a result of it, there is reduced drug clearance. So the inference of the this study by Blanton and colleagues was that of the intervention views, paracervical block, gabapentinoids, IV acetaminophen, ketorolac, dexamethasone showed significant post-operative opioid-reducing effects. An improvement in pain score were only found to be significant for paracervical and NSAID. Subcutaneous and intraoperative installation of local anesthetic, transverse abdominal spleen block, and dexmedetomidine failed to provide any significant benefit. Then this is another study that was conducted by Ding and White, and they found about ketorolac, compared ketorolac, fentanyl, and dexamethasone. And Ding and White found that the patients treated intraoperatively with ketorolac versus fentanyl reported lower pain score, lesser incidence of nausea, and less analgesic requirement in post-anesthesia care unit. And another study was conducted in 2016. Cochrane review actually examined the 7 RCTs with 422 patients and concluded that dexmedetomidine resulted in decreased breakthrough opioid consumption in the first 24 hours and there was no significant reduction in pain scores. So what are the limitations of opioid sparing techniques? Limitation was that we might not be able to manage patients' expectations. That is, a cancer patient will be having severe pain. So he'll be, I think opioid is the best method to manage such a pain. And so in that case, managing our patient's expectation with opioid sparing technique might prove to be difficult. And the adverse effects and drug interactions of non-opioid medication are another limitation of the opioid sparing technique. Multiple drug interactions could occur, multiple side effects could occur. So this is also a limitation of the opioid sparing technique. And the thing is the inadequate treatment of cancer pain. And this inadequate treatment can cause even stress and pain in the patient and can even result in cancer recurrence. And another thing is the need for anesthesia providers who are skilled in regional anesthesia. And next is the need to develop novel monitors. Now there are monitors like this EEG, and this entropy, electromyography, then measurement of pupillary size, heart rate variability, etc. But these are all these monitors could not accurately quantify nociception. So there is a need to develop novel monitors to quantify nociception. Then I would also like to mention about the existing prescription practices. That is, in a study that was conducted in a center, it was found that even in 70% of the patients in whom ERAS protocol was used were discharged with opioids. So they were discharged with opioid prescriptions. If they have told of pain in the immediate while discharge. So they were actually 70% of the patients were discharged with opioid prescriptions. This could actually worsen the epidemic because it is not. There is a popular myth that there's a popular myth that it was told that in US and all. It was the increased use of perioperative opioids that have led to the opioid crisis, but it is actually not. So there is no study that supports this statement. It is actually due to the overprescription and the overuse of prescription opioids that have led to the epidemic. So what we have to do, we as physicians can do, is beyond discharge, we have to give drugs. If at all we have to give opioids, we have to give weak drugs with less addictive potential, and we also have to educate patient that he can go in for an addiction in the future if he goes on using this, and has to be used for only a prescribed time. So opioids are actually highly effective and perhaps the most effective drugs in pain management. But from all these discussions regarding the side effects on one side and highly efficacious nature on other side, we have now understood that it is a double-edged sword. So the remaining multimodal analgesics are insufficiently effective against moderate to severe pain when used alone, because no amount of acetaminophen could replace morphine. Morphine is morphine and acetaminophen is acetaminophen. So no amount of acetaminophen or no amount of wishing can convert acetaminophen into morphine. So what is important in the end is what is important in the end is patient comfort via pain control and patient safety, that is absence of major adverse effects. So this could be provided by a judicious use of opioids in a time-limited, monitored, and lower effective dose regimen along with non-opioid adjuncts. And this is the concept that is present in opioid sparing techniques and which is actually feasible also. But I think we should not go for opioid eradication because the efficacy or effectiveness of pain management becomes low when we are using opioid eradication techniques. So we should go for opioid sparing technique, which is feasible and which is effective also. And there should be more studies to bring about more balanced and rational approaches for this. So these are my references. Thank you.
Yes.
Thank you, Dr. Ansha, for your extensive talk, elaborate talk on opioid sparing anesthesia, and for having given us adequate depth on this topic for the past couple of minutes. Thank you, Ansha. And now over to you, Sanish.
Thank you very much, Linette ma'am and Dr. Ansha for this wonderful enlightening lecture. Now we have seen different aspects of opioids in the current and evolving trend in anesthesiology practice. I welcome Dr. Jayashree Sood once again to join us for the audience query interaction.
Thank you, I'm there.
Yes. I think all the postgraduates have presented their topic well, taking us through right from the pharmacology to the current different aspects of use, what we are familiar with. And the third session, Dr. Ansha was actually introducing us to a different era where opioids are sparingly used, but as she mentioned, as the double-edged sword. Towards the end, the conclusion was a little bit, I think, maybe because of the lack of evidence, utterly favoring an opioid sparing. How do you feel about the session?
You're absolutely correct, Sanish. It was an excellent seminar, and must congratulate the postgraduates and the moderators. And each speaker so vividly told us everything about the opioids. And as I said, although we've been using it this right from the first day of our PG, and newer drugs are coming, and every time we get to learn something more. But ultimately, we always have our own choice, our favorite that we would like to use. So many of the opioids have stood the test of time, and we are still using them. And others, if you see in your own practice also, it has dwindled away. And of course, the last one spoken by Ansha is the hot topic these days, and people are drifting towards opioid sparing techniques. But there are many important things, some precautions, and we have to be cautious while using opioid-free anesthesia.
Ma'am, I think it's also because of the rise in the trend towards a regional anesthesia. Yes. Where even the role of the space of general anesthesia also has come down.
Yes,
yes. With the onset of minimally invasive surgeries.
Very true.
Previously, people never thought that they can anesthetize a segment of thoracic level only.
Yes, and so, for this, ultrasound has been a real boon for the anesthesiologist, and that is very essential in our armamentarium now. So can we ask our moderators for their expert comments? And
we'll start with Kirti ma'am.
Yes, Kirti, thank you so much.
Just one thing that Doshis talked about morphine, but opiates, the history of opiates is 8,000 years old, recorded history. And it was used in the Babylonian civilization, and it was very popular in India. And recorded is that in India, it was used for surgery. So opium, in the form of opium, it was used. And it was very effective. One side effect which she did not say and nobody was talking about was rigidity due to morphine and fentanyl. I have seen a very bad case of rigidity following fentanyl. And it became difficult to ventilate the patient at that time. And then we had to give a muscle relaxant to break that cycle. So that's an important thing.
I do remember, Kirti, you're right. There was a few years back, there was one company, and we all felt it was that product that was coming from that company, and then we banned it. And then, of course, for a long time, it wasn't in the market. So that was the time we did have an adverse effect, yes, with fentanyl. Thank you so much, Kirti. And Dr. Krishna?
Yes, ma'am. We are all very familiar with the use of opioids, and each one of us have our own techniques. In fact, it's very interesting to see the different techniques of even just the use of opioids. Some just give a big bolus in the beginning and then expect it to cover the entire duration of surgery. Some keep giving smaller boluses, some rely on infusions, some give a small dose before extubation. It's very interesting to see the pattern And in fact, I always like to learn based on how the patient fares through the surgery and wakes up at the end of the surgery. Probably no one technique is the best. Everyone has to develop his or her own technique, which is a learning experience for every individual. It's more of a realization rather than learning from books or hearing from others. So that makes the use of opioids very interesting. And the new concept of opioid sparing anesthesia, I personally don't agree with opioid-free anesthesia even now. So opioid sparing anesthesia, that adds another dimension to this practical use of opioids.
So I think each patient also might be different. Like some are more sensitive to opioids, some are very resistant to opioids. So in a way, each patient is a learning experience, especially when you are giving anesthesia per se. Forget about opioids. Sure. Each agent sensitivity matters. But I think, as we mentioned towards the last lecture, we have been using dexmedetomidine as an adjunct for our general anesthesia. We knew that there is a little bit of opioid sparing. We need not give the same opioids what we used to give with or without dexmedetomidine. So the concept was already there, I think. So knowingly or unknowingly, we were all sparing it. But when some advocates are asking us to go for a strict limitation, maybe drastic reduction in the opioid, then it's a different game. Because now I think there are a good number of enthusiasts for this opioid sparing anesthesia.
Especially the ones doing onco.
Yes.
Dr. Linette, please, your expert comments.
Actually, if we come to the younger generation, no, they would like to do an opioid sparing technique, but we are all used to that, so much used to having, as ma'am said, we have been using morphine and the older things from day one of our PG. We'd like to use what we have been familiar with. But the younger generation, with the advent of ultrasound and newer drugs, they would like to use these opioids sparingly and have a balance and multimodal approach to the patient. That is what we normally see in the hospital setup.
Very true, Linette. Sanish, there are some questions which need to be answered in the question answer.
Actually, one of the questions was out of context, why we shouldn't give muscle relaxants if we are not able to mask ventilate. It's slightly out of context. So I think we'll forget about it. I think unless and until we have Sugammadex with us, be cautious when you are taking off the spontaneous breathing. That's what I think. Then there was a question on buprenorphine for post-op analgesia. Can we get an input from the panel, like how we are using buprenorphine? I think some centers are using buprenorphine, maybe because it's longer acting compared to our fentanyl. Dr. Krishna, any?
Yeah, buprenorphine we do not use routinely in the intravenous or intramuscular form because it's not good for moderate to severe pain. But buprenorphine as an additive for regional anesthesia, especially central neuraxial blockade, we have been using it very often, right from a dose of 75 micrograms up to 300 micrograms in spinal anesthesia to prolong the duration of analgesia. The advantage that we try to get from buprenorphine over using morphine is that buprenorphine has a ceiling effect, and hence the propensity of it to cause the respiratory depression, about which we are afraid with when we are using morphine in the central neuraxial block, is far less with buprenorphine. In the same context, I would also like to bring out an interesting feature about buprenorphine, that if we see the dose response curve of the buprenorphine, it is described to have a characteristic bell-shaped curve. So if you actually plot the dosage of buprenorphine on x-axis and the analgesic effect on the y-axis, as you keep increasing the dose, the analgesia keeps increasing up to a level, and then you see a ceiling effect Up till here, it's all, you see it with other opioids also. But paradoxically, when you increase the dose further, the analgesia comes down with buprenorphine. So in fact, the analgesic component comes down with buprenorphine. So that's why you get a characteristic bell-shaped curve with buprenorphine. It's very interesting with buprenorphine. Probably it's because of its interactions at the receptor level at various plasma levels that we see this effect. So one thing is we always have to be in the therapeutic range only. And the utility is more with regards to its use as an additive or adjunct in regional blocks.
Plus, Krishna, even the buprenorphine patches that we
Patches,
use.
yes.
Exactly. They are very
popular now
in cancer patients.
Cancer.
And we, in our institution, we have done a study on buprenorphine where oral buprenorphine was used both as pre-medication and for post-op analgesia, giving single dose, which acted as pre-medication, intra-op analgesia, as well as post-op analgesia because of its long duration of action.
Okay, there was one more query in the chat regarding opioids in oncosurgery. I think the limit is different because when during the talk on opioid sparing, there was a mention on reducing opioids because of the concern of tumor progression and all. But when it comes to palliative, then actually the option weighs more in favor of morphine. So how is this transition? Like oncosurgery, intraoperatively, we have a strategy, and maybe in a post-discharge palliative mode, we totally shift, or is it the same? I would like to hear from Linette, ma'am. Any?
Actually, these patients, one of the concerns why this opioid sparing effect came into view is because of the effect of opioids in cancer recurrence. So in that aspect, if you think of, but we don't have much of a literature to substantiate either of the fact, because they say on one hand, it modulates cancer or immunity, and on the other hand, they say whether it pain can also cause in the intensity of pain can be a factor in cancer, cancer patients. So whether this is this can be correlated, whether it by literature, it is very difficult to say at this moment.
I
So
think
it's actually a question
more of RCTs are required.
When you advocate opiates for cancer pain, then it is in patients who are already advanced cancer and usually not really, treatable as such. It is just to give them palliative care that we are using it.
End of life. Basically, the end of life care.
Right.
Yeah.
And now we are even looking at alternatives to that.
I think even the nerve blocks are getting more commonly used in the palliative care, like celiac plexus block, etc., so that patients will be absolutely relieved of pain and distress factor, and their dignity can.
It's come in the WHO ladder as well.
Actually, our next ICA webinar is also featuring pain management, acute and chronic pain management in different age groups. We'll be discussing in detail in our next ICA webinar. Now I invite Dr. Jayashree Sood, our CEO, Indian College of Anesthesiologists, to give away the E-Certificate of Appreciation to the postgraduate presenters.
Thank you very much, Dr. Sanish. So we are really very proud that our students are really doing so well, and they are the future of the country. And I'd like to congratulate Aditi, Siva, and Ansha for their excellent presentations. So these are the certificates. Siva, that's for you. Can we see Aditi's again? Ansha, that's you. Thank you very much. And can we see Aditi again? And Aditi, yeah. Yes.
Thank you, ma'am.
Thank you,
So
ma'am.
heartiest
Sending the e-certificate
congratulations
Thank you, ma'am.
and keep it up.
Thank you, ma'am.
This PG assembly session will be on our YouTube channel also from
Yes.
tomorrow onwards.
Right. So coming to the end of this very nicely performed webinar, I'd like to thank the moderators, Dr. Kirti, Dr. Krishna, and Dr. Linette for their valuable inputs and having moderated the students so well. It was so beneficial for all the students and for the others as well. And once again, Aditi, Siva, Ansha, excellent presentations. Thank you very much. And we hope to see you in other PG programs.
Thank you, ma'am.
And thank you, Dr. Radhakrishnan and Dr. Sanish, and of course, the clinic who is helping us in performing these webinars very seamlessly. Thank you very much and see you all next Wednesday, same time, Sanish.